You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
All righty. Hey, everyone. Back here again, Spine Citations Classics. Sohum.
Jose.
Hey, guys, and it's Jay. So glad you guys are back with us again.
All righty. So first things first, let's touch on a little background. When we're talking about disc herniations in the lumbar spine, it's important to understand the purpose of the discs. So these are cartilaginous shock absorbers between our intervertebral levels that are comprised primarily of three anatomic regions: the end plates, which articulate with the cranial and caudal vertebral bodies, the nucleus pulposus in the center of the disc, which is a soft, squishy material, and then the annulus fibrosus, which is, as its name suggests, the fibrous, tougher tissue on the periphery of the discs. Usually disc herniations happen in younger active patients. That sometimes can have a story of lifting heavy stuff, or being active and then feeling sudden electric shock down the leg associated with back pain. And this happens usually around the PLL, or the posterior longitudinal ligament in the lumbar spine, and affects the transversing nerve root, so the L5 nerve root at the L4-5 level, most commonly. Usually the symptoms patients experience are related to the mechanical nerve compression as well as inflammatory mediators at the local site of herniation. And management is often conservative to begin with no advanced imaging required unless there are red flag symptoms present, like progressive weakness, Cauda-Equina syndrome, loss of bowel or bladder function, things like that. And then if symptoms persist after conservative management, then we talk about advanced imaging with MRIs, and patients are then usually candidates for surgical intervention. And the surgical intervention we discuss usually includes lumbar discectomy, microdiscectomy, and endoscopic discectomy. So just in brief. We got a couple of papers to present for you guys, so I'm going to go ahead and jump into the first one here, which is the SPORT trial, which stands for surgical versus non-operative treatment for lumbar disc herniations, from the Spine Patient Outcome Research Trial. So the original paper, it was a randomized controlled trial to compare discectomy versus conservative treatment for lumbar disc herniations, and that was out of the Dartmouth Medical Center, Weinstein et al., and published in JAMA in 2006. So they originally had a 2-year follow-up, and then came out with updated results in 2014 with 8-year follow-up, which they published in the Spine Journal. So we'll go ahead and kind of just touch base on both of these papers. So a little bit of background, like we mentioned, discectomy is the most commonly performed procedure for patients that have symptomatic disc herniations that fail conservative management. And the SPORT trial was initiated to kind of fill this void where we had a lack of solid, level 1 evidence and long-term results on comparing conservative management with surgical discectomy. So the original cohort in the JAMA article consisted of a randomized cohort, and then in the future paper they added a prospective cohort from other surgical centers. So that's kind of relevant here. So they, like I said, they started with their first medical center, and they compared these randomized groups with conservative treatment and surgical microdiscectomy. And the inclusion criteria were basically radicular pain greater than 6 weeks, and a single intervertebral level disc herniation. So it's important to know that the outcomes they looked at were both measured with an intention to treat and an as treated analysis, and that'll become relevant when we talk a little bit about the results here. So in the first paper by Weinstein et al., what they looked at was the intention to treat analysis, and in primary and secondary outcomes, which were consistently higher for the surgery group at 2 years, but not statistically significant. So these outcomes included sciatica bothersomeness, work status, patient satisfaction with symptoms, self-rated improvement, physical function, as you can see kind of in the charts there. The statistically significant improvement in secondary outcomes was a sciatica severity and self-rated improvement. And this was, probably the most important part of this original paper. And it's important to note that their intention to treat analysis, what that means is that they basically take the randomized groups, and even if patients crossed over from, being assigned surgery to deciding they wanted to go with conservative treatment or vice versa, they treat the groups as they were originally randomized to avoid any bias. And so this has been published and known to sometimes underestimate the efficacy of treatment. So if anything, this is kind of underreported data. So then they also performed an as-treated analysis where they take the randomized groups, and then if they cross over, they move them into whichever group they end up in. And this showed strong statistically significant advantages for surgery at all point in time for primary and secondary outcomes. So strongly in favor of surgical treatment versus continued conservative treatment after 6 weeks of symptoms. So in the 8-year follow-up outcome, Luria et al. Also, they added this cohort that was non-randomized, as well as, they continue to follow the original randomized cohort 8 years out. So again, in the intention to treat analysis, all the measures 8 years out favored surgery. Only statistically significant were the same secondary outcomes of sciatica bothersomeness and self-rated improvement. And then there was, in the as treated and combined analysis, all outcomes were statistically significant in favor of surgery, except for work status, which is not a super significant outcome in my opinion. So basically the conclusion of this sport trial is in patients that have lumbar disc herniations with radicular symptoms after 6 weeks of failing conservative treatment, surgery has superior outcomes for relieving symptoms and improving function, including up to 8 years out from intervention. And this is important because this is, one of the first long-term follow-up randomized control trials to demonstrate this superiority of surgical intervention for disc herniations.
Yeah, it's just super juicy for any spine surgeon, right? I mean, it's clearly saying, okay, we should do surgery because it's going to make you feel better. So it's one of these things that you see quite a bit, like on any questions or anything like that. The sport trial is brought up and it's highly quoted, as you see. But just like you mentioned, the whole intent to treat and as treated analysis made all the difference in this, because the intent to treat actually wasn't very well. It was trending towards being significant, but it wasn't actually statistically significant, which, if you're on the spine side of things and, you want this is a pretty high level paper, you wanted to say, hey, surgery is better than non-operative management. But truthfully, it, like you mentioned, there's so much crossover, right? You probably should look at it as the as treated, because there was such a huge shift in patients going from non-op to surgery and from surgery to non-op. Then when you look at that, just like you said, yeah, it shows that surgery is beneficial as far as relieving these symptoms. So
yeah, definitely. I think that's kind of why I maybe kind of glanced over the combined analysis on the bottom of the slide too. And like you mentioned, so they, their intent to treat is great, but they had tons of crossover. The as treated is great, but it has a little bit of bias. And so then the combined analysis, I think that's a good happy medium. And again, that was, like you said, in statistically significant in favor for surgery for all outcomes. So I think that, like you mentioned, I've been pimped on this paper. We've talked about it in journal clubs in my program, and it's definitely all over the OIDI and Ortho bullets. So definitely a super high yield paper for disc herniations.
Absolutely. Got to be like one of the most high yield papers that residents get. I feel like you will hear about the sport trial, whether you're into spine or not. So definitely glad that you guys went over this one for sure.
All righty. Well, we'll keep moving along, go to the next paper, and I'll pass the reins over to Jose.
Thank you, sir. Basically, what I'm presenting here is posterolateral endoscopic extrusion for lumbar discectomy. This was presented by Gideon et al. 2002 on Spine. And basically, this study was conducted a retrospective view involving 307 consecutive cases of lumbar disc herniation done by posterolateral endoscopic discectomy. Basically, the main point of this paper was basically to review go back to see when these patients have gone through these surgeries and want to basically see the outcomes of it in terms of complications, et cetera there. And basically the little background of it, this idea about using endoscopic approaches has been in existence for the last 90 so odd, almost 90 years so far. And over time there, as you can see here in these time chart here, it basically shows you that over time has gone down different approaches there, especially for spinal decompression, as well as also later on, they have improved it for non-visual posterolateral cutaneous nucleotomies. And then within the last 25 years or so there, we developed it because there was one approach, it was called transforaminal approach, and we came in there, and then afterwards we had the transluminal approach to as well. For the next paper, I'll explain a little further detail about these two here. And then so what they did was, to do this, they have reviewed 307 cases involving the post-lateral endoscopic technique approach during an 8-year period, and the follow-up for it was started on post-operative day 2, and then from 2 weeks, 1 month, 2 months, 6 months, 12 months, and every 12 months. And then the outcomes, as I mentioned, was evaluated based on 2 methods. The first was to perform the assessment based upon 1 year after the initial operation of the surgery itself. And then the second part is basically send out questionnaires to a patient. It was basically a 5 questionnaire, basically asking them what was basically how was the surgery? Will you recommend it? Do you suffer any kind of symptoms? For example, do you suffer from leg pains or muscle weakness or any cramps, etc.? Basically, just give them their assessment, see, and we just plotted a trajectory on based on it. And then afterwards, I put a note here, author uses a freehand biplane C-arm guided access and optimal trajectory and to endoscopic landmarks. In the next, as I mentioned, in the next paper, I'll go a little bit in detail of this because it's quite significant in using approaches for which one to use foraminal and transluminal there. And then from the results there shows that overall that they had a very high, rather high satisfaction rate of 89.3% of the cases, showing that had very high satisfaction overall there. 90% of the patients had good satisfaction rate at 1 year post operative. Of course, just like anything else, you have to monitor its complications there. They were very slim there, but among some of the most common ones that the most they have ever seen was basically this arthritia was found there, as well as also others include thrombolytitis and also the infections there, which eventually that all the patients made full recovery from those complications there. So basically, from the surgery that was complete here, based upon different levels and so forth, because about 95% of all the surgeries that was done at different levels, mostly from L4 to L5 and then L5 to S1, and which shows that shows overall that using the endoscopic approach was very effective and very efficient for when compared to the regular open approaches there. And of course, since it falls under that big minimally invasive surgery approach, which basically that had very little use, like when you would do in an open surgery, like having a large incision, using a lot of retractors and so forth. But because of this approach here, it shows that it could be a suitable approach for patients, that if it's warranted to it, especially compared to the open or any other microdiscectomies approaches there, especially for, let's say, for example, for laminectomies, spinal decompressions, and even disc removals as well.
Yeah, I think that's a pretty good conclusion there. Is basically like you see a lot of patients post-op from spine surgery, and they have pretty severe spasm and pain associated with the dissection we have to do just by disrupting those paraspinal muscles and elevating them off of the bony structure. So, that's kind of one of the values of endoscopic surgeries. It's muscle sparing, and patients don't have to experience, the pain associated with dissection. And then obviously this is a retrospective review, so there's no control group and nothing to compare these outcomes with, which is probably one of the limitations I see with this study.
Yep. And it's something actually that just the whole endoscopic surgery, I haven't had a whole lot of experience with it myself, but I think between this one and maybe that next paper that we're going to talk about, but I mean, if you're having similar outcomes compared to some of the other studies that's been out there for open procedures, I mean, it sounds like a win-win if you can get the learning curve for these types of procedures and you still have the similar outcomes, faster recovery, quicker back to work, and things like that. It seems like it's very helpful. Like I say, I'm still learning a whole lot about the minimally invasive type techniques, but this paper did show that it's safe, and you can use this for these types of herniations.
Yeah. Cool. Yeah, actually, I haven't seen any endoscopic either. We do micro discs at my institution with the microscope, which is
exactly
semi MIS, but not a true endoscopic, I guess.
Yep. Same.
Cool.
Yes, we do a lot under the scope, which is nice. The scope is pretty nice, especially in a setting with residents. Like I'm not exactly sure how everything is set up with the endoscopic procedures, but with the scope, there's two sides. So, the attending can be on one side and you can see the exact same thing that he sees from the other side. And you are still able to get your hands in there and kind of help out as well. I don't know if it's that easy to do that with the endoscopic type procedure. I feel like that's like a one-man show.
Yeah, for sure.
But a lot of times it does involve as a one person, because you're driving the camera and then the actual probe itself there to do procedures there. And one of the disadvantages sometimes to endoscopic a lot of times is that it takes like a longer time there. It's kind of like when you do robotic surgery. Yeah. Sure, it's very similar to it. Sure, it gives you a minimum surgery approach there, but the thing is that a lot of times that since you're not actually doing directly on it, it takes a lot more time to learn the functions, as well as even to visualize the area that you're working.
Yeah, that's definitely a good point.
Yeah, I've definitely heard some residents say like, hey, it's just, you got to be really good at your anatomy, because just from what you're seeing is kind of difficult just because it's not so open,
Yeah, and that's what our staff all say too is, master the open techniques, and you can learn endoscopic in practice. It's you got to learn the anatomy and be good at it open before you can do it through a scope.
Absolutely.
All right, I'm going to bring it on to the next one, which is kind of on the same train of thought here.
Okay, and then as I mentioned earlier there, this next paper here is basically was presented by Rune et al. In 2008, published in Spine. This is basically to show the different approaches to different in comparison to with the open approaches, particularly the intralaminar and transforaminal lumbar discectomies, along with microscopic approaches there. So basically, we're just comparing all to see how compatible these approaches are. So,
and I think, just sorry to interrupt you, but just important to highlight, this is a prospective randomized controlled trial. So this is level 1 evidence that all orthopedic surgeons are on the hunt for. So whenever you see that, it's worth at least looking at these types of studies.
Basically, for the little bit background about it, as I mentioned from my previous presentation there, the concept of endoscopics has been around from decades ago, but it's only from the 1980s and on we see this more and more common there. And when you compare to convention, according to previous studies, when you compare to regular conventional open surgeries, they had produces good results, not just good results, but also sometimes better outcomes there, particularly decreases post-operative infections, complications, or any other, or even other, maybe even in many cases that it's the patient can have the surgery and be returned home the same day there. And in addition to it, as the last point there mentioned, that it also reduces any tissue damages and causing other issues around the surrounding structures, particularly if you surround, let's say, a blood vessel, a nerve, so without any further concerning about any interference there. And so for the methods there, what they did was they enrolled 200 patients who have known to have systematic disc herniation, have undergo discectomies. And they divide in the paper, they did inclusions based upon different backgrounds there. For the transforaminal, sequential material located cranially below the lower edge of the cranial pedicle or caudal, now over the middle or the caudal pedicle. And the second one is lateral radiology evidence of foramen was not overlaid by the pelvis beyond the middle of the cranial pedicle, and all extra and intrafemoral disc herniations there. Basically, usually the transforaminal is basic because of the way you position the patient, because the patient's usually positioned on a prone position, and usually with the transforaminal approach, you can do it from the lateral approach to access to get to the disc and so forth there. However, and that's usually you have that around the issue will come is when you have to deal with lower levels, particularly let's say L4 to L5 to S1 levels. where sometimes it could be hindered by surrounding structures like muscles, blood vessels, et cetera there. And by that point, you may want to switch over to an interlaminar approach there. As mentioned there, it'd be mainly because this is more of a within the spinal cord instead of be out, like what you do for a transforaminal there. And basically, as an alternative, instead of using the transforaminal approach. Then afterwards, all the data will be collected to assess pain score, as well as for back and leg, and as well as addition, because this study was done in Germany. They will do the North American Spine Surgery German version of that NASS instrument, as well as also the Austrian Lower Back Pain Disability Questionnaire. And overall, when they did the results there, it was shown that that there has been improvement in both of the endoscopics and endoscopic groups have been shown that has shorter duration compared to the conventional microscopic approach. In addition, all the complication has shown improvement in both for pain, as well as also blood loss has been shown to be very minimal, and when compared to the to regular and even the regular open and even the microdectomy approach, which have shown that this overall this have shown that both the in full endoscopic approaches has been shown to be very, very, very helpful in determining to improve patients' outcomes compared to microdectomies and even open surgeries there, as mentioned before. And of course, and as mentioned earlier there, a lot of times of these approaches, you have to really see what is best for based upon what level you're in, and as well as also what approaches and how you do it there. Because one of the key thing is mentioned in the paper that as mentioned that you have to use the C-arm very extensively in order to see the angle and positioning of your needle there, because in order to prevent, is able to see if you can be access to it either through a transforaminal or if not to an intraluminal approach there. And one thing I forgot to mention there is the fact that because of the full endoscopic approach has been shown to less dependent on any pain meds compared to using conventional approaches there. Okay, and basically overall there it shows that the full endoscopic approaches has been shown to be very effective there in terms of it's been shown to be very effective, sufficient, and safe compared to the microscopic surgical approaches. And in many cases there, it both its advantages, despite its disadvantages, there's still a lot of advantages towards it, and as well as with minimal damages to the surrounding tissues and even minimizing any complication overall there. So as we stated earlier, that the only issue can be with these endoscopic approaches is basically the timing, because it's not like a regular open surgery. It takes some time there to get the good angle visualization, and a lot of times you have to depend on good anatomical landmarks in order to give you a bearing to see where you're going there. Because if that is hindered for a reason, like for example, it could be a lower aortic spine, could be arthritis. A lot of times it could be very difficult at times, and you have to readjust it, which can take time there. But once you get the good hang of it, you will find out that it has great outcomes overall.
Yeah. And just like you mentioned, I think there's probably that learning curve, right, where there's going to be a period of time where these cases are taking you a whole lot longer than if you were to do just a standard minimally invasive type approaches. But looking at this particular paper here, and this is most likely because this was done by individuals who were used to using this technique. And, so they're probably not just like the first time guys doing this. They've probably done this quite a few times, but the mean operating time for the endoscopic group was 22 minutes and the minimally invasive group was at 43 minutes, which I was like, oh man, like I said, I haven't really had a lot of hands-on with this, but I found out, the time is that much difference. That's actually pretty impressive. It's almost like you can do two surgeries as long as it took you to do one, But I don't know exactly when they started counting, right? I don't know, is that as soon as they make an incision? I don't know, is that like counting when they had to start doing their X-ray fluoro shots or not? So I'm not exactly sure what they're saying, but I mean, that's pretty impressive, that difference in the operating time that they showed.
Definitely. And one of the things that I thought about when seeing that, Jay, was like, oh, well, maybe they're going quicker and they're, maybe it'll lead to worse outcomes or higher risk of reherniation. But based on their results, it's, the outcomes were equivalent. Reported outcomes were good. They had no statistically significant increase in reherniation. So basically what my conclusion from this was that it's faster, there's less blood loss, and the outcomes and chance of reherniation are essentially the same. So I was like, it kind of was, interesting information to me, because like Jose was saying, I would have thought the setup and using all these tools and stuff would definitely be added time.
Exactly. And I mean, think about it on the other side of it, as far as like a patient who's coming in because they have, some disc herniation or something like that, right? And okay, so one minute someone's telling you, well, I can make an incision about an inch and a half or something like that and do your procedure through that, versus, I can make it 3 or 4 inches or 5 inches. It's just, people just like to hear this whole minimally invasive or, smaller incisions and things like that. I think more than anything, right, these outcomes are pretty similar. And, I think this paper did show that people were doing better with rehab and getting back to work and things like that, which I think is important. And a patient probably would think is important too. But I think out of all of it, I think, learning these skills now as young surgeons like me and you all, I feel like it'll be a very good marketing piece for you to get a job, and for you to get patients. I think patients like to hear minimally invasive. They like to hear laser. They like to hear small incisions. They like all these things, and it makes them feel a little bit more safe about the procedure, even though you still got to explain to them like, hey, this is still a real surgery. I may have to, if something goes wrong, maybe we do have to make a larger incision and change our plan and things. But I think being able to be that particular guy for your practice can be a big benefit. One of the things that I've seen from, just like, I'm in the middle of doing interviews for spine fellowships, I feel like most places, if they have older staff who's been out of training for a certain, extended period of time, they tend to do less of this type of minimally invasive type procedures, versus if they have a new guy that's come out in the last 5 years or so. Because I just feel like they expect that new guy to kind of have some grasp on some of this stuff. So just something I've been kind of noticing.
That's interesting. And I wonder, one is like, they already have an established practice. They don't need marketing. They don't need to bring patients in, and they're comfortable in what they know. And so probably all of those factors, right? Like they want a new partner, they want somebody to bring them to something they're going to bring to the table. Obviously, from your perspective, you need to have something about you that brings patients to your practice. And like you're saying, I've kind of seen the same thing in joints as well, where, a lot of the patients are asking by name for, minimally invasive hip replacements, which is, just an anterior hip replacement with a 10 centimeter incision instead of a 12 or 14 centimeter incision.
Exactly.
And then, they want to know that there's a robot in the room, though it may not be doing much. It's just comforting, like you mentioned. So
they like to hear it. They like to hear it. They like to know that's the kind of case they've been involved in. They know that it's newer and up to date and things like that. So I think patients are liking it. I think it's a good strategy if you're in the job market, and you see, I think these things all have a learning curve, right? But I think if you know what you're doing with them, they all tend to have good or similar outcomes. So I think it's definitely worth learning.
Cool.
It's certainly there, especially when you learn about the robotic navigation systems. It's very similar to the endoscopic approaches there. In the beginning, it takes a while to get the learning curve there, but after repetitive usage and understanding its systems and functions, you become more of an expertise on it with over time there.
Exactly.
Yeah, for sure. Yeah, we had some staff resistant to using nav for scoli when I first started, and now we're doing basically all of our scolies, especially neuromusculars, under nav. It's like almost, I would say in our lifetime or our education, it's become the standard of care. It's like, at least I may be overspeaking just because I'm not obviously familiar with what happens everywhere around the country, but at least in my institution, it's become the standard of care.
Yeah, I think I think it's good to learn, all this stuff, right? You need to learn how to do navigation, you need to learn how to put in screws through, using landmarks, just freehand. You need to learn how to work through the scope, you need to learn how to work through the loops. So I think, for newer surgeons or people who are interested in spine or joints, I think you just need to get somewhere where you can learn all of these things. You want to learn open, close, percutaneous. I mean, you need to know all of these things so that when you get out, you can kind of choose what you would like to do and how you would like to do things, because you have a little bit of experience of everything. So that would be the best idea, I think.
Cool. Well, I'm going to kind of flatten out the excitement a little bit here with this next one, a little bit of basic sciences for everyone. This is actually a pretty interesting paper out of the JBJS, published in 2001 by Burke et al. So it's a cross-sectional study, and essentially what they wanted to look at was they did a ELISA to look at the production of pro-inflammatory cytokines, interleukins, prostaglandins, in patients who had radicular symptoms, which they refer to as sciatica, in either due to a lumbar disc herniation or in patients with discogenic low back pain, which is kind of a nebulous term that I personally, haven't seen a ton because some of my staff aren't fully believers in that. So basically what these guys did, I guess I'll give you a little bit of background, sorry. So there's some studies out there talking about disc herniations. And like I mentioned earlier, a lot of the pathology comes from mechanical compression of the nerve root, but also from when that annulus ruptures, there is a production of pro-inflammatory cytokines similar to like a tendon tear. And that causes you to have an inflammatory cascade and eventually pain. So in patients that have degenerative disc disease and discogenic back pain, there's been some basic science research that show they have hypersensitive nerve endings at the end plates, and that may be related to their pain. But like I said, overall discogenic low back pain is kind of nebulous. And there's no real imaging study to diagnose it. Some people do discography, which is essentially when they do, I think they do a saline load under fluoro into the disc to see if that recreates symptoms. And I do believe there's been some papers that have come out that say that violating the annulus via discography actually accelerates degeneration of the facet joints. So I'm not really sure if people are still doing that. I've never heard of it, but it was something that these authors did to confirm the diagnosis of discogenic low back pain in the patients they enrolled. So like I mentioned, they were comparing patients who underwent discectomy for sciatica or radicular symptoms from a herniated disc. And then they were comparing that to disc material from patients who underwent lumbar interbody fusion for discogenic low back pain. It's kind of the thought behind that. For those of you who aren't familiar, when you have this discogenic low back pain, your discs are in between your vertebra and the facet joints, or the joints, posterior to the disc and posterior to the thecal elements that are moving, causing degeneration of the disc. So if you're fusing that level and you're no longer having motion at that segment, in theory, it should relieve pain. So that's why these patients were indicated for interbody fusion. So the markers they looked at were, TNF alpha, IL-1, IL-6, IL-8, and PGE2. And then here's some exclusion criteria on patients that they had to take out of their study. So the results of note were that significant quantities of pro-inflammatory mediators were produced in both, the disc herniation and the discogenic back pain groups. And there was no TNF or IL-1, but high presence of IL-6, IL-8, and PGE2. And there was a significantly increased quantity of IL-6, IL-8 in the discogenic low back pain groups compared to the disc herniation group. And so, that was interesting. They're present in both, but definitely in high quantities in the discogenic back pain. And I thought that was slightly interesting as, we see a lot of back pain. It's one of the most common complaints that primary care doctors see, that ER doctors see. And we don't have great things to tell these patients other than, continue your conservative care, continue your PT, your lumbar stabilization, do supportive stuff if you need chiropractic, yoga, stretching, massage. Basically what I tell patients when I see them is, if it helps, it helps. And so I think having this assay or this biochemical test could be of value. And that's kind of what the authors concluded, is that these pro-inflammatory mediators in patients that underwent interbody fusion for low back pain suggest that they have a role in the pathology. And one, it could potentially lead to diagnostic testing to aid the diagnosis, as well as a target for non-surgical treatments. For example, anti-inflammatories, which is what we tell these patients all the time, naproxen, sometimes you do a Medrol pack, and all these affects the pathways. If you guys remember way back to basic sciences, those arachidonic acid pathways that produce pro-inflammatory mediators, that's what we're targeting in these patients with back pain. So this is a nice little paper, I guess, just providing some evidence behind what we're telling these patients. So it makes me feel more comfortable when I tell somebody that, hey, maybe take some naproxen for your back pain. I know it'll actually help. That's kind of what I drew from this.
Yeah, I think, just like you're saying, back pain is one of those issues. I mean, we always highlight and tell people, back pain is multifactorial. And, truth of the matter is we don't have a great grasp on all of it, on how to make all back pain go away, why some people have a normal MRI and have horrible back pain, or why some people have a horrible MRI but have no back pain. It's like, it's one of those things in medicine. But I really did like this paper, just kind of seeing this, the basic science behind it all, and seeing, the more the nucleus pulposus is exposed, seeing like they start to have more of that inflammatory reaction going on. I just thought it was interesting overall. And just like you say, hey, NSAIDs should help with this, injections toward this area, hopefully that should help with this, so I thought it was just interesting overall.
Yeah, and that'll be a perfect segue to our next paper, talking about things that can mitigate inflammation, such as steroid injections, like you alluded to. So this is what I thought to be a pretty interesting paper as well. Prospective randomized controlled trial published in Spine in 2002 out of HSS by Vijay Vad et al. And so what this author was interested in was comparing transforaminal epidural steroid injections with saline trigger point injections in patients who had sciatica symptoms, i.e. lumbosacral radicular symptoms, resulting from a herniated lumbar disc. So kind of just going back to the beginning of this talk when we talked about background, the first step of treating these patients, we obviously have shown that in patients who have 6 weeks of persisting symptoms, surgery has superior outcomes. But prior to those 6 weeks, there's a lot of data that shows that a lot of these disc herniations can resolve with conservative care. And so conservative care includes things like physical therapy, NSAIDs, oral steroids, chiropractic, PT, yoga. And part of that arsenal includes these transforaminal epidural steroid injections. And it's also something you can try for patients who may meet surgical criteria, but are slightly hesitant. So that's kind of what Dr. Vad was interested in looking at, is to see if these injections were truly therapeutic by comparing them with low back trigger point injections. And then of note, I think it's important that all these patients had the same PT rehab protocol and bracing protocol. So trying to, keep it as, similar as possible in both groups. So we'll kind of talked about this a little bit here already, but a little bit of background. Yeah, so one of the things that he mentioned also in this background is that, and I've seen this because I'm doing a little bit of research here on these epidural steroid injections with one of my attendings here at IU, but there's really poor reproducibility in the outcomes of epidural steroid injections. And some studies cite 40% success rate. I've seen 80% success rate. So it's kind of all over the place. And so that was one of the reasons he suggested doing a randomized trial on this. So they had 50 patients and they divided them into two groups. I think it's important to note that the patients were not blinded to treatment. So they knew whether they were getting an epidural or a trigger point injection. And then they had pretty specific inclusion and exclusion criteria. And their primary outcomes of interest were both subjective and objective scores, Roland-Morris score, visual numeric score, and then finger to floor distance, which is basically just a measure of hip flexion, and then an overall patient satisfaction score. So the results, important to highlight what they defined as a success is what they called a satisfaction score of good or very good, increase in Roland-Morris score of greater than 5, and pain reduction greater than 50% reported at 1 year after treatment. So group 1, the transforaminal group, 84% achieved success, as I defined, compared to only 48% in the trigger point injections. And this was statistically significant, and it is important to note that the group 1 did achieve maximal improvement slightly faster than the trigger point injection group 2. So, obviously, we talked about the value of prospective randomized control trials. I probably hit that over the head a couple of times today, but this is what we look for in orthopedics and probably in medicine as a whole. to guide our treatments is level 1 evidence. So, this was a good study in showing that, at least compared to trigger point injections, these epidural steroid injections may have a good role. And, I've seen it in clinic, and I've seen it here in my institution. Is that something we use pretty significantly in these patients that have lumbar disc herniations? And so, obviously limited by sample size. Overall, they ended up with an N of 48, so they lost 2 patients to follow up, and the fact that patients weren't blinded to treatment. But I think overall, this kind of combined with the paper we talked about before, talking about pro-inflammatory mediators, it kind of all ties together how these steroids are working and what pathways they're working on, and why they're helping patient symptoms. So I think that was the value of this paper for me.
Yep, it's a really good paper. The whole blinded situation, that of course that's going to make a difference, but how much of that can you do? Is some of the ethics and things like that get a little difficult with the blinding sometimes. But of course, the people who know they got the actual treatment always, usually in studies, they tend to do better. And the people who knew that they got the more like placebo like treatment, they tend to do a little bit worse. That's goes into like some basic psychology stuff. But overall, I like the paper. Just from the clinic side, it does seem like epidural steroid injections do help. So I'm glad that this one did push towards that direction. And I think it was a good paper overall. If anybody can put together a paper where you can take people and randomly put either steroid or saline into their spinal canal, I mean, hey, go for it. But otherwise, I think this was really good. Yeah,
for sure. And this is interesting. At least I kind of had a personal I think bias to this paper, because we're looking at some epidural steroid stuff here and seeing because our injectionist here, he's a neuroradiologist, and he uses contrast dye. I think it probably does prior to putting in the steroid, just to make sure he's in the right place. And there's some debate out in the world where you should put these injections. And so we're kind of looking at the flow patterns of the dye and trying to see if there's any superiority of one over the other. So nobody steal my project out there, but that's what we're working on here at IU.
Sounds pretty interesting. They even mentioned this whole situation about a washout. I don't know, you might have mentioned that, but just saying that, does putting this fluid around this area kind of wash out some of those inflammatory factors that we were just mentioning in the previous paper? Does washout play a role in some of the pain improvement as well? I just thought that was kind of interesting, because I never even thought about it. But yeah, plenty of good stuff. And I think this is the last one, guys.
Yeah, that is it.
Awesome. Well, again, guys, you all did a wonderful job. I'm hoping everybody who listened in is really able to get something from these talks. And I hope you all are enjoying the new Spine Citation Classics segment. All right, guys. See you guys soon.
See y'all next time.
See y'all next time.